Heart disease is the leading cause of death in the United States. Thinking heart disease only occurs at an older age is both untrue and dangerous to your health. Rhythm and flow, understanding the cardiovascular system. Tonight, on Call with the Prairie Doc, health information based on science, built on trust. Good evening and welcome to the 21st season of On Call with the Prairie Doc, medical information based on science, built on trust. Thank you for joining us tonight. I'm Dr. Kelly Evans-Hullinger, your Prairie Doc host. Joining us in the studio this evening on the campus of South Dakota State University in Brookings are Dr. John Wagener and Dr. Thomas Waterbury, both from North Central Heart. Welcome, guys. Thanks for coming up to Brookings tonight.
Thanks for having us.
Yeah.
Appreciate it.
So tell us a little bit about yourselves and paths of training, both cardiologists. Dr. Wagener, where did you go to get all your medical training, and how'd you end up back in Sioux Falls, South Dakota?
Yeah, so I did my undergrad education in the University of North Dakota in Grand Forks and stayed there for medical school. Once I finished there, I went out to Durham, North Carolina at Duke University for my medicine training. And then from there, I spent 5 years at the Cleveland Clinic doing general cardiology, interventional cardiology, and an extra year in structural intervention, so percutaneous valve surgeries.
Great. How about you, Dr. Waterbury?
So I did undergrad at the University of Nebraska in Lincoln, and from there I did medical school at University of Iowa in Iowa City, and then went up to Rochester, Minnesota at Mayo Clinic for internal medicine residency, cardiology fellowship, and then stayed there and did interventional training as well.
Yeah, great. So both interventional cardiologists. What does an interventional cardiologist do that people might not know about?
Yeah, so interventional cardiologists, we do diagnostic coronary angiography, so looking at the heart arteries percutaneously through a hole in your wrist or a hole in your groin, however you want to say it. We also do angioplasty and intervention, so placing stents in the heart arteries. And that's, part of it. And we do, right heart catheterization, so looking at the pressures in the heart. And then there's other things we can do with valve therapies and, PFO closure, so closing holes in the heart and things like that. So a lot of different things we can do.
Right. But if you or your loved one find yourself in a cath lab having a heart attack, it's someone like you that's in there taking care of them, right?
Right.
Yeah.
Right.
Right.
We spend a lot of time in clinic seeing patients, though, as well, and working on the preventative side of things, in addition to doing procedures.
Yeah. Great. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about cardiovascular health. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but please provide contact information when you submit your question. So let's get to some questions. We've already got some rolling in. I'll start with this first one. With all the research and improvements in cardiac care, why are we still seeing frequent cardiac disease? Has there been an increase or decrease in the past 10 years in coronary artery disease? So I think everyone knows that this is kind of #1 cause of death in the U.S. and much of the world. Is that getting better or worse, do you think, Tom?
I think there's still plenty of coronary disease out there. Our strategies and medications for preventing coronary disease certainly have improved over time, but there's also a strong genetic component to coronary artery disease that at this point we can't modify. In addition to some several lifestyle factors, but patients are also living longer as well, and so later in life we see more coronary artery disease as you get more advanced in age. So I think it's a combination of factors there, but certainly, it still remains a prevalent issue in our nation and in the world.
Yeah. John, if you had to pick one thing that you could tell someone to help decrease their risk of heart disease, what would it be?
Stop smoking.
Yeah.
Yeah, so smoking is one of the biggest risk factors for any type of, whether it's coronary artery disease or peripheral vascular disease. And not that I would tell patients to do this, but if you stopped all your medications, but you stopped smoking, you reduce your risk by 50%. So that's really the big thing, is if you're smoking, stop completely. Not, I smoke one cigarette every other day or something like that. Get off of it completely. You do yourself a lot of good.
It's a good reminder. I think everyone thinks of things like lung cancer, lung disease, but huge risk factor for vascular disease.
Yeah, absolutely.
Yeah, good. We have an online viewer who was once diagnosed with scarlet fever, treated with antibiotics, and wonders about an abnormal EKG. So maybe let's talk a little bit about rheumatic fever, I guess, which maybe is a different entity, but we don't see it much anymore. But classically, what kind of things could rheumatic fever cause?
Right. So, I mean, the biggest thing that we see or think of, and we don't see it so much in the U.S. anymore, but still seen in third world countries, is valvular disease, and it causes really thickening and stiffening of the valves, and causes something we call stenosis there later in life. And so that's kind of the biggest thing. In terms of an abnormal EKG, with a history of scarlet fever, probably just need to see a physician and have a good comprehensive cardiac exam. And if there's some abnormalities on the exam, then may be worthwhile doing some imaging of the heart to look into that a little bit further.
Yeah, abnormal EKG can mean so many things. We have a viewer calling in saying they have AFib caused by a valve problem. This person is on warfarin, but wonders if there's any other treatment for this condition specifically caused by heart valve problems. It's a great question. What would you say about that, John?
Yeah, so there's a lot of different valve problems that can cause atrial fibrillation, and the treatment so if you're on warfarin, you're trying to prevent stroke related to the atrial fibrillation. If you have mitral stenosis, that's called valvular atrial fibrillation, and that's where somebody needs to be on warfarin versus the other blood thinners like an Eliquis or a Xarelto, which you might hear about on the TV.
Yeah.
If you have mitral regurgitation that causes atrial fibrillation, it may mean that you need something fixed with that valve, but those are really the two types of valve problems that can cause atrial fibrillation.
Yeah. Are there studies ongoing about mitral stenosis, AFib, and these other blood thinners? Will we ever have something that's not warfarin for those patients, do you think?
We haven't seen that yet, but patients who have had valve repairs or regurgitation, we don't necessarily consider valvular AFib, so they're still okay to be on Eliquis or the oral novel anticoagulants.
Yeah.
So.
And the other piece of that is if you have valve disease has been fixed with a mechanical prosthesis, you still have to be on warfarin. Yep. We were at North Central Heart, we were a site for the PROACT 10A trial that closed early, looking at Eliquis versus warfarin for aortic valve, a certain aortic valve prosthesis that was a mechanical prosthesis, and warfarin was still superior due to increased events in Eliquis. So for right now, it's still warfarin for patients who have a mechanical prosthesis.
Yeah.
And if atrial fibrillation is related to that.
Right. The new drugs can be great for some people, but it looks like there's still going to be a place for warfarin for a long time to come, huh?
Right.
Okay. We have a caller who would like to know the consequence of having a slow leak from the aortic valve and what treatments are available for it. So we'll assume that means aortic regurgitation. Can you comment on a little bit about that?
Yeah, so again, aortic regurgitation is sometimes not uncommon, and if it's just a trivial or a mild leak, that something can be washed and generally doesn't cause any issues over time. We do serial imaging, so serial echocardiograms to follow that. Where people can get into trouble if you have severe aortic regurgitation that is either causing symptoms, or if you're not having symptoms but it's causing changes on the function of the heart. And that's where we really get concerned about that leaky valve. So if you do have regurgitation, something that, depending on how bad it is, you just got to make sure you do your due diligence and follow up with your doctor or follow up with your cardiologist.
Yeah. We see so many, the echoes are probably a lot better than they were 10, 20 years ago even. So we pick up on a lot of abnormalities in the valves. And not everybody ends up needing something for that, but they do have to be watched and know what symptoms to watch for. We have a viewer from Madison who has what they called an aortic expansion, and the physician is watching for any changes. So we'll assume that means an enlarged aorta, I guess. What do you typically recommend if you find that on an echocardiogram or some other imaging?
Yeah, it's not uncommon that we pick up some enlargement of the ascending or descending aorta on imaging, whether it's incidental on CT imaging or on our echo. Generally, that's something that we just follow longitudinally over time until it gets to a certain cutoff where we look at doing an elective repair, unless there's some underlying, connective tissue disorder or something that, would require a lower cutoff due to risk of complications with that. But generally, it's risk factor modification, making sure the blood pressure is under good control. Smoking is a big risk factor for aneurysm formation, so if smoke, then need to stop smoking. But generally, it's just sort of longitudinal imaging follow-up and making sure that there's not rapid expansion of the aorta, or it's not dialing to the point where we need to be looking at elective surgical repair.
Sure. All right, we have a viewer who was given a stent at age 50 and got another one in the same vessel at 66. Now 76 and wondering what is the best way to check how well the stents are functioning. So what do we follow up people who've had a stent? How do we know if they're working or if they're open?
Symptoms.
Yeah.
Yeah, so really outside of, worsening chest pain or dyspnea or shortness of breath when you do activity, there's really no other reason. We just check randomly to see if stents are open. Outside of having an acute heart attack, stents are only helpful to reduce symptoms.
Yeah.
So we don't necessarily do stress tests annually. We used to do that 10, 15 years ago, but recent evidence and trials and so forth have shown that that's not helpful. So really, again, we follow symptoms. If you're having symptoms, that would be a reason to get checked out, maybe have a stress test, things like that.
Yeah. I'm glad you brought that up. I feel like I have patients who are disappointed that they're not getting their annual stress test anymore like they did, 10 or 20 years ago, but there's good reason for that.
Yeah.
Exactly.
Yeah.
Okay, good. Let's see, what would an ablation be appropriate for someone who's not tolerating their atrial fibrillation on certain medications? So, an ablation of this abnormal heart rhythm, when do we do that? Why do we do it?
So with abnormal heart rhythms, and the most common one we see is atrial fibrillation, the indication to do something for that is if you're having symptoms or have some change in the structure or function of your heart because of it. So in that scenario, we try to do a rhythm control approach to try to keep patients in normal rhythm. That can be accomplished one of two ways, with a procedure called an ablation, where essentially going through a vein, usually in the leg or through the groin, and run a catheter up and map out where those abnormal circuits are coming from in the heart, and burn them out essentially, or burn a scar in there. The other option is antiarrhythmic medications. Some patients, especially younger patients, prefer not to be on medications long term if they can avoid it. In that scenario, ablation's a great procedure to undergo, and the technology anymore is very successful in terms of reducing the symptom burden or rhythm burden of things like atrial fibrillation or other types of tachycardia or abnormal heart rhythms. But also, if you've failed medications and are having more issues with recurrent arrhythmia, ablation can be a very effective way to deal with that.
Good.
I think it's important for people to know too that if you are in atrial fibrillation and somebody finds that and you're asymptomatic, just leaving yourself in atrial fibrillation for years and decades can be detrimental later on in life. We used to have this idea that a rate control strategy, meaning leaving you in atrial fibrillation because you're feeling good with your heart rate normal, was okay. Well, over time, we've noticed that that's led to a lot of mitral regurgitation, tricuspid regurgitation, heart failure problems. So now I think if you talk to our electrophysiology colleagues, we're a lot more aggressive trying to get people back into a normal heart rhythm, especially when you're younger.
Sure. Yep. So it depends on the patient to some degree.
Right.
Good.
But it's an effective strategy.
Yeah. Good. We have a question about TAVR, so TAVR. Can you tell us just what is TAVR? People probably, it's been common enough that a lot of people know someone who've had this procedure done, and why do we do it, and how is it done? Yeah,
so TAVR is a procedure we do for patients who have aortic valve stenosis, and typically calcific aortic valve stenosis, so meaning that you've had calcification of your aortic valve that's caused it to be narrow and it doesn't open all the way. And if you're having symptoms because of that, we generally recommend a valve replacement. Historically, that was done with open heart surgery, a sternotomy, where surgeons cutting out that diseased valve and sewing in a new mechanical or bioprosthetic valve, and so on. But over the past decade or so, a little bit longer than that, we have now a way where we can replace the valve by going through an artery in the leg and putting in what's essentially I call a stent valve. So it's a big stent that has sewn leaflets inside of it. And so you put the stent valve inside your own aortic valve, and when you expand it, you blow it up with a balloon or you release it, it pushes your diseased valve to the side of the heart and leaves behind the stent that holds open the narrowing, and then working leaflets that are inside that open and close so the valve doesn't leak. Generally now, if you're older than, you could even say 65 or 70, no matter whether you're low, high, or intermediate risk for valve replacement surgically, and you're a candidate based on a number of tests, that's the way we replace the aortic valves. And we do a lot of them every week now.
It's really revolutionized the way we deal with aortic stenosis.
Yeah, and fast. I mean, I feel like I wasn't a resident that long ago, but then it was still just very high-risk people that we were doing this in, but it's proven to be effective and had good longevity even for those lower-risk patients.
Yeah, and especially for folks who were in their upper 80s and 90s who didn't have an option for treatment 10, 15 years ago. And now we can replace their valve and a lot of times leave the hospital the next day. Yeah. And they're doing great.
Whereas the old option was just really risky for those patients.
Yep, and a lot of times it was palliative care, medical therapy.
Yeah, great, cool. Well, recovering from a cardiovascular episode can be a daunting process, but luckily there is support available for patients. Prairie Doc reporter Sam Schauer learned more about cardiopulmonary rehab.
Jesse Walsh is the Cardiopulmonary Rehab Director at Brookings Health System.
Cardiopulmonary is cardiac, where heart patients have had either bypass or stents or something heart-related. The pulmonary is patients that have had trouble with lung problems, COPD, asthma. COVID has been a big one this year that we've had.
Rehabilitation for cardiopulmonary patients consists of learning and exercise.
We use it to make sure that they're not having any problems. So it could be medication, we want to build their strength and endurance up. It's just basically if they have questions, we do assessments with them, that might go over the nutrition, the exercise, medication, the psychosocial, kind of how they're doing overall with it.
Anyone who has had heart or lung problems can attend these sessions.
Each patient will come up, they'll start with their weight, we'll do their blood pressures, we'll do a kind of a nice easy warm-up, and then we'll have them do like 3 different stations for about 10 minutes on each one, if they can. Some of them might have a little more trouble than others, but that's what we're looking at, trying to build that strength and endurance up.
And the sessions are an hour a day, 3 days a week for 36 sessions. The rehab consists of 4 phases. Walsh says phase 1 is after surgery as an inpatient at a hospital to start strengthening their heart or lungs before being discharged out.
Phase 2 is when you're on the monitor, when you come up to rehab, and then once you've hit phase 3, which is when you're off the monitor, so when you no longer have the EKG monitor system on, then they're kind of considered phase 3.
Walsh says phase 4 is just exercising for fun. The goal is for patients to adjust their lifestyle to have a healthier heart and lungs, which Walsh and his team strive for.
That it builds that strength and endurance up so they're able to do things at home without, like tiring out, so we want them to be able to do what their normal activity is, and hopefully more.
Walsh says cardiopulmonary rehab is an excellent choice for people who need guidance after a heart or lung surgery.
It's one of those things that's kind of a life-changing thing. Until you experience it, you don't really know. And it's one of those things that I think that they just need that support. They need something, they need that guidance, somebody to kind of help them out and what they should be doing. Is this normal? Is this not normal?
Great. How important is cardiac rehab after someone has an event like that, Tom?
Cardiac rehab is absolutely imperative. We at least offer it to all of our patients after they've had an acute coronary syndrome event, heart attack, or have had a stent, or have heart failure. It's very important getting patients back on their feet, There's been plenty of data showing mortality benefit for patients who complete cardiac rehab. So not only does it provide supervised exercise and gets patients going again, but there's a lot of education pieces that are really important in terms of diet and lifestyle changes. So, you know, it's something that's critical to the longitudinal management of coronary disease.
Yeah, and luckily I found even in very small hospitals in South Dakota, cardiac rehab is available. I think I have patients who've done it in DeSmet, South Dakota, for example, so accessible for a lot of our patients. We were talking a little bit over the break about something that's come up a lot in my clinic, coronary calcium screening. So can you tell us a little bit, John, what is a coronary calcium score, and what's the meaning of this?
Yeah, so coronary calcium score we're looking at is we're getting a CT scan of the chest and the heart. We're looking at how much calcification there is of the coronary arteries. And we're using that to really determine a risk of cardiac events over time. It doesn't necessarily mean that you have narrowing of the heart arteries themselves. And so, you know, I tell folks in clinic when I see them that have had coronary calcium screening and their score is elevated that the heart artery has 3 layers. That calcium can be in any layer, but what really matters is the calcium that's impinging flow and in the inner layer. And so if somebody has an elevated coronary calcium score, depending on how high it is, it may change their risk or how we determine their risk of events over time. So risk for heart attack, cardiac arrest, and things like that, or needing a stent. And so that changes medical management. So somebody who is otherwise not on a low-dose aspirin or a high-intensity statin, so like Lipitor or Crestor, that may push us as providers to help prescribe that for them. And our guidelines, if the calcium score is, you know, above a certain point, we do some stress testing just to see in case somebody's having, you know, they don't do enough activity to elicit, you know, coronary symptoms and so forth, so we'll do that too. But it doesn't necessarily mean that you have blockages or anything like that that needs stenting. And the other thing too is that if you've had a coronary calcium score and it's high, we don't trend coronary calcium scores. So once it's high, it's high. You know, no matter what people say, I tell them you don't need another one. You know, you don't have to go do that. That's okay. But we do need to make sure you're taking your medications and you're seeing your providers and staying on top of those risk factors.
Yeah, good. What, how do you use that in clinic? So there's kind of cutoffs for scores, I suppose. Some people get stress tests. Some people you do a symptom review and reassure them. How does that go when you get a consult about a high coronary calcium score?
Yeah, so, you know, generally when we see these patients in clinic, you know, you have a calcium score that's generated and then a percentile based on your age and gender. And basically we're looking at, you know, what your risk would be of an event down the road. So anything, a calcium score above 400 puts you in a higher risk category. So usually when we see these patients, we'll talk to them about symptoms. You know, if it's somebody who's active and has 0 symptoms, don't necessarily need to do further testing, but really focus or hone in on risk factor modification. So like John talked about, are there medications that we can start to reduce the risk of a cardiovascular event down the road? Statin medications, controlling cholesterol and blood pressure, getting the diabetes under better control, stop smoking, a low-dose aspirin, those types of things. If it's somebody who doesn't, you know, do a lot of activity, then and is completely asymptomatic, then we'll think about stress testing for additional risk stratification. If there are any exertional symptoms, then that would be an indication to investigate further.
Right. And I tell people, sometimes people will ask me, should I get this done? And that's kind of a hard question to answer. First, I look for symptoms, because if you're having symptoms, then this is not the right test in most cases.
No,
would you agree,
right,
John?
exactly.
Yeah.
Oh, if you're having symptoms, you need a stress test.
Yeah.
Because this isn't telling you what the actual blood flow of the heart muscle is. This is just saying there is calcium or there isn't, and it can change what your overall risk is.
Yeah. But don't try to interpret these things by yourself, right? Get an expert opinion. Okay, good. We got a question from Iowa about what does it mean for heart muscles to be stiffening? So I don't know if this person was told this based on an echo result or exactly what. So how would you respond to that?
Yeah, so, you know, generally in the cardiology world, we talk about that as, the old term was kind of diastolic dysfunction. So when the heart contracts, we call that systole. When it relaxes, we call it diastole. So when the heart over time gets a little bit stiff or thickened and doesn't relax as well as it should, it can elevate pressures inside the heart. Particularly on the left side of the heart, the lungs drain into that side, and so those pressures get pushed back on the lungs and can cause symptoms like shortness of breath and things like that. Usually it's something that happens over time. There's certain types of disease processes that can cause it, but usually it's more, aging, high blood pressure over time. And generally, the first thing to do is start a good exercise regimen, and again, sort of modify risk factors, blood pressure, fluid status, those types of things.
Sure.
But that's essentially what it means, is that the main pumping chamber has become stiff a little bit over time.
Sure. All right, we got a viewer wondering why hypertension is commonly treated with 3 separate medications. I guess let's just talk about hypertension a little bit, what kind of heart disease do we see as a result of hypertension that's untreated? What do you see in your practice, John?
Yeah, so hypertension can be one of 2 things. It can be, well, I wouldn't say essential, because high blood pressure is never essential, but primary. So people just have high blood pressure for a cause we don't necessarily know, or secondary due to some other organ dysfunction that raises the blood pressure. But the things that can happen with untreated high blood pressure, you can have problems with stroke, heart attack, kidney disease. You can have diastolic dysfunction and heart failure from that, so where the heart doesn't want to relax appropriately. Sometimes it can even affect your heart valves and so forth, but that's typically what we see.
Yeah. And to this question, I mean, some people have excellent control of their hypertension with a single medication, and some people it's 4 or 5 medications, and I don't have a great answer for why that is. Always, I don't know what you tell patients.
And sometimes blood pressure is best treated by hitting it at different angles, is what I sort of tell patients. So all these drugs have different mechanisms, and we kind of choose from different classes based on the mechanism. And sometimes blood pressure that's hard to control, instead of going up and up and up on one medication, it's better to hit it from a few different angles to get it under better control.
Good question, though.
Yeah.
What can cause a complete AV block when there seem to be no warning signs? Interesting question. I just saw a case of this in my clinic recently. So what is complete AV block, Tom, and is there a cause to it?
So complete AV block, usually there's chambers of the heart. So the top chamber usually starts the electrical signal conduction, and then that passes through a node called the AV node, and then passes down to the bottom chamber to cause it to contract, or the bottom chambers to contract. Complete AV block is essentially a block in that electrical highway, or the electrical fibers there, where the top chamber and bottom chambers aren't communicating through there. Generally that's due to fibrosis or aging of the conduction system. There are certain types of infections, Lyme disease, that can cause complete heart block, but generally it's more, aging of the conduction system in our practice. And the way to treat that is generally a pacemaker.
Yeah.
It can be caused in the throes of an acute heart attack as well. That's a little bit different in terms of management sometimes. But generally, those patients will need a pacemaker if there's no identifiable or reversible cause.
Sure. Good. A related question, can pacemakers cause heart failure and valvular regurgitation because of a lead passing through the valve? Have you seen that at all, John?
100% you can. So the way the pacemaker goes in is typically through a vein in the arm, and that goes down to the right side of the heart and goes through the tricuspid valve. And depending on where that lead sits along the tricuspid valve, it can hold open the leaflets and cause it to leak, and sometimes leak severely. If that happens, folks can have problems with heart failure, usually on the right side of the heart, not necessarily the left side of the heart. Sometimes, if somebody's paced 100% of the time for a long period of time, you can have left-sided heart failure from that too. But generally, it can cause tricuspid regurgitation and right-sided heart failure.
This person, interestingly, actually asked about mitral valve regurgitation, which shouldn't be a pacemaker-related issue.
No, but sometimes getting a certain type of pacemaker can fix mitral regurgitation. So if you have heart failure, and you have what's called the left bundle branch block, and you get a biventricular pacemaker, a lot of times the regurgitation go completely away.
Yeah, it's amazing.
Yeah.
All right. We have a caller who says they can ride a bike with ease but struggles walking a half a block. And he's curious if this problem might have to do with his heart. How would you counsel that patient?
Yeah, I mean, certainly it could be a cardiac issue. Sometimes when you're upright or doing more strenuous activity like climbing stairs and things like that, that's where we can see cardiac manifestations. When we stress patients, sometimes we can do it with a bicycle, stationary bicycle versus a treadmill, And you'll see that it's actually harder to get the heart rate up on a stationary bicycle. So it may just be a difference in the level of physiologic stress there. Not always, but that may be contributing.
Sure. So it might be worth looking into for that person. We have a Facebook question. A relative of this person chews tobacco. Can chewing tobacco have consequences similar to smoking in regards to the cardiovascular risk? John, what would you say about that?
It's a little different. I mean, there's some risk, but really with smoking is the toxins that get into your lungs and then get into your bloodstream. I mean, the biggest thing with chewing tobacco is oral cancer, right? So we still recommend not to do that.
Yeah, not probably as much, but we'd still love for that person to be able to quit. We have a caller curious about our options for rehab if the insurance company says that cardiac rehab is not necessary. It might be a hard question to answer, but for what indications do we always recommend cardiac rehab? It's not for everything.
It's not for everything, and part of that is reimbursement and what is covered by insurance for patients, so they don't have to pay out of pocket for that. Indications if you've had a heart attack or an acute coronary event, if you have heart failure, if you've had a heart procedure done, cardiac surgery, you've had a stent put in, some of the structural interventions, those are all generally covered by insurance and and for patients to undergo cardiac rehab. Options if your insurance company won't pay for it, there's still options in terms of being part of a cardiac rehab program, but sometimes insurance companies are very specific about what types of things that they'll cover, based on your cardiac condition or procedures that you've had done.
And they'll cover only so much in a given year too. So if you have had multiple issues, sometimes you only do a certain amount of sessions before they say you've maxed that out. So I've seen that a few times with my patients as far as reimbursement and coverage.
Well, a healthy cardiac system is important to everyone. What ways can we continue to keep a healthy cardiac system? Prairie Doc reporter Sam Schauer has more on this.
Dr. Jose Teixeira is a cardiologist with Monument Health in Rapid City, and he says coronary artery disease is the most common type of cardiovascular disease to die from.
About 80% of heart disease is due to coronary artery disease, and that is blockage in the arteries in the heart.
Coronary artery disease and most other heart diseases are developed from an unhealthy lifestyle.
The coronary artery disease is a foodborne illness, and is caused by bad nutrition and not good lifestyle.
Risk factors that come into play are typical for an unhealthy lifestyle.
If you have high blood pressure, if you have a high cholesterol, if you have diabetes, if you smoke, if you have a family history of coronary heart disease, all of those risk factors increases your likelihood you're going to develop heart disease and die from heart disease. There is no question about that.
With all these risk factors, Dr. Teixeira says diet is the most important part to a healthy cardiac system. Even exercise with a poor diet doesn't help you.
Exercise is great, it's very important as well, but you cannot exercise yourself out of a bad diet. You can't, if you exercise vigorously 1 hour a day and you have a terrible diet, you're still going to get into trouble with atherosclerosis and coronary artery disease and strokes and so on.
According to Dr. Teixeira, increasing daily fruit and vegetable intake benefits your heart health dramatically. Another food he brings up, which was tested in multiple studies to improve heart health, is chili peppers.
There was an interesting study actually came on the Journal of American Cardiology in 2019 about chili peppers. And it was a study done in Italy. If you will eat chili peppers, you also decrease your cardiovascular mortality, your stroke mortality, and cancer mortality.
He also says any chili pepper will do, and that it doesn't have to burn your mouth.
Season your food with chili peppers. It's great for you. It doesn't have to be, the hottest of the hot.
But for Dr. Teixeira, a healthy cardiac system in patients is incredibly important to him, and taking care of your heart is a matter of commitment.
We only have one heart, and the heart pumps about 5 liters or more per minute. And it takes the blood to the rest of the body to bring nutrition and energy to all the tissues in the body. from your head to your toes. So the heart is absolutely crucial.
So what do you counsel patients on? Maybe they've come in and they've had a heart attack and you're discharging them from the hospital about things like diet, like Dr. Teixeira was talking about.
Yeah, so I mean, he made some great points there. We usually focus more on the Mediterranean style diet, which is more of an anti-inflammatory diet. So, lots of fruits, vegetables, whole grains, olive oil, anti-inflammatory foods like that, leaner proteins, more fish and chicken. And then, for patients with struggle with high blood pressure, keeping the salt or sodium intake low, that's also important for heart failure patients as well. But, in general, the Mediterranean diet has been shown to decrease your risk of having recurrent cardiovascular events and increase your decrease your mortality.
Yeah.
So.
And really, there's been a lot of diet research about weight loss and cardiovascular events, and Mediterranean's kind of what's panned out.
Yeah, it wins for everything so far.
Yeah. So, we actually had a question about heart failure. What is heart failure? What are the common symptoms? What do we mean by that?
Yeah, so heart failure is a syndrome. It can be either because your heart's weak and can't pump blood out of the heart, or stiff, like we talked about earlier, and the heart can't fill appropriately and blood backs up. And so symptoms you can have with that is you can feel short of breath, you can have swelling in your legs, you can have fatigue, you can have trouble sleeping because you can't lay down because you feel like you're drowning. Sometimes you gotta prop yourself up. But again, it's a syndrome. It can be caused by multiple different things. Is really kind of the end stage of some of the heart diseases that we treat commonly.
Yeah, so kind of a big bucket of lots of different things that can lead to that. We had an emailer question. I had a heart attack and stents implanted several years ago in my 50s. Am I destined to have heart failure as I get older? And is it diagnosed by symptoms? So what symptoms would this person watch for? And would you say that they're destined to have heart failure if they've had a cardiac event like that?
No, absolutely not. I mean, while plumbing issues or issues with the arterial supply or blood supply to the heart muscle can be a cause of heart failure, just because you've had stents or have coronary artery disease does not mean that you're destined to have heart failure. Just as John alluded to, the symptoms to watch out for would be, worsening shortness of breath, having fluid retention issues, swelling, those types of things. But it doesn't mean that you're destined to have heart failure by any means.
Yeah, good. We have a viewer who had COVID in August and has experienced heart flutters ever since. Is there a correlation, or I guess could you talk about, are there correlations with COVID-19 infection and any heart diseases?
Yeah, there are. So a lot of it, unfortunately. At one point there was a study early on in the pandemic where it showed about 40% of people have some sort of cardiac involvement after they've had COVID. And it can be an array of things, whether it's myocarditis or so forth, but specifically fluttering and palpitations and so forth. Yeah, we do see it quite a bit. You probably see it as well. And what we've noticed is that a lot of folks will have their heart rates go up randomly without really even doing much activity. It can be very distressing. Some people think, or some of us think, that it might be related to dysfunction of part of the nervous system that controls our resting heart rates. There's some cross-reactivity of antibodies with the nervous system that can affect your heart rate, and so treating that can be difficult. But there's definitely a correlation. We see it every day in clinic right now.
Yeah,
absolutely.
Yeah. What do you advise those patients to do? Do you put them on medicines at times, or?
Generally we do some additional workup to make sure that there's not some sort of abnormal rhythm going on, or there's a structural issue from COVID infection itself. But generally we try to, a lot of times they're patients who are previously very active or younger patients who notice it. We generally try to avoid medications if we can. Sometimes we have to use medications, at least in the short term. It tends to improve over time. There's also probably a deconditioning component, from being ill. So we generally recommend, regular exercise regimen, adequate fluid intake, sometimes some compression stockings for those types of symptoms. But generally, medication isn't required long term, at least.
Yeah, but that might be something real that patient is noticing.
Right.
For sure. Let's see. We have a caller from Sioux Falls who is diagnosed with congestive heart failure and is taking 80 milligrams of Lasix or furosemide. What's the highest dose you can take of furosemide?
As much as you need. I mean, honestly, 80 milligrams is not uncommon.
Yeah.
All it depends is how well you absorb it, which is different for everybody, what your kidney function is, because if your kidney function is not as good, you need higher doses for the medication to work. And there's different types of diuretics you can use.
Yeah.
Some work a little bit better than others, but you can give a couple hundred milligrams a day, and so again, whatever it takes to get the job done.
Yeah. All right, we had a caller who had a pacemaker put in but found out that she no longer needs it. What are the risks and benefits of getting it removed?
Yeah, I mean, that's a good question.
Yeah.
It depends a little bit on what the device is and how long it's been in place. Those leads tend to scar in place over time, which increases the risk of trying to remove it. Not to say that it can't be done, but if it's something that hasn't been in there very long, then the risk is probably relatively low to have that explanted or taken out. But if it's been in there a long time, that certainly increases the risk of removing that.
Got it. Okay. Let's see. We've got a viewer. We talked a little bit about atrial fibrillation and rhythm control. This viewer has had several cardioversions. 2 have it worked. Would it be okay to have another? Can you tell us what's a cardioversion? How often do they work? Let's make an assumption this was for atrial fibrillation. Maybe it was for something else, but
a cardioversion is where you give the heart an electrical shock to try to jumpstart it back into rhythm, essentially. 70%, 80% first time. It all depends on the individual patient of how successful it will be. Folks who have untreated sleep apnea, it's very hard for cardioversions to work. If you already have structural heart disease, it could be a problem. But if you've had 2 and it hasn't worked, could you do a third? Yeah, obviously you could do a third, but that's a time where I would start seeing electrophysiologists talk about an ablation or antiarrhythmic medications. And a lot of times our electrophysiology colleagues, even after an ablation or especially after prescribing antiarrhythmic medications, will then try another cardioversion with that medication in your system to help.
Sure.
A lot of times it can work. But I would probably add something in addition to just doing another cardioversion at this point.
Try to set yourself up for success of maintaining normal rhythm or restoring it.
Good. You mentioned sleep apnea. This person had a question. If you're a side sleeper, what side is best for you to sleep on for your heart? Are there any good sort of sleep tips for heart health that you would have?
Yeah, I'm not sure there's a side that makes
I've
a
never heard
difference
that before.
cardiac-wise, but certainly if you sleep on your back and you obstruct at night, that can create a host of cardiac issues, including high blood pressure. It increases your risk of arrhythmias like atrial fibrillation. So, having good sleep hygiene is important, for cardiovascular health and decreasing your overall stress hormones. I'm not sure that there's an exact position that is desired, but
I find the electrophysiologists are sending patients back to us for sleep studies more often than I would have expected before I was in practice. So there must be a really strong relationship for those heart rhythm problems.
Absolutely.
Yeah, cardiovascular health in general, including heart failure.
Yeah, good. This is a great question from email. If you live out in the country an hour from a medical facility, we have those places in our part of the world, and you have a heart attack, is there anything you can do while you're waiting for an ambulance or waiting to get to the hospital? How would you advise that person in the boonies?
Yeah, if you can take aspirin, do it.
Yeah.
Obviously, call somebody for help right away. Don't try to do it yourself. And if you have had heart disease and you have sublingual nitroglycerin, carry that with you and use it if you can. But don't try to do everything on your own. That's where you can get into trouble. You know? So call for help.
Yeah, we deal with, we're used to talking about the cath lab and how we treat heart attacks, but in a huge part of our state, that's not the first thing that we can do. What do we do? And even in Brookings, South Dakota, if someone comes in with a ST elevation MI, what are the first things that we do before they find you in the cath lab?
Yeah, so generally we try to determine what the transfer time would be to a cath lab where we can manually open up the artery with catheters and balloons. If that transport time is going to be over 2 hours, then there's medications that we can give, and those medications include a clot buster drug generally. If there's evidence of an occluded artery on the EKG or heart rhythm tracing, to try to restore perfusion or blood flow through that artery before we can get them to a cath lab capable facility. But the first medications are always aspirin, and sometimes a super aspirin like Plavix or Brilinta, and then a blood thinner called heparin or something along those lines, and then maybe a clot buster drug.
Yeah, good. And if someone is at home, how much aspirin are they supposed to take?
Well, it depends on what you have, but 325 or 4 baby aspirins, that gets you 324.
Yeah.
We usually tell patients to chew it.
Get it in your system as fast as possible. Great. We have another question from Rapid City. With previous stents, is it necessary to keep on a low dose of aspirin forever? What do you tell people about their aspirin after they've had an intervention?
Yeah, so I tell patients, if you have a coronary stent, to stay on a baby aspirin 81 milligrams daily indefinitely. Where we get into trouble is when patients stop their antiplatelet therapy completely, and then you increase your risk of stent thrombosis or clotting off that stent. So generally, as long as you're not undergoing a procedure or have major bleeding issues or something that requires you to stop the aspirin, generally we tell patients to stay on that lifelong, at least a baby aspirin.
Yeah. And how long after a stent is placed can someone think about having a surgery that they might need to come off of it for a time? What advice? I guess it depends on the surgery, maybe.
It depends on the surgery. It also depends on why the stent was placed. It depends on your bleeding risk. There's some evidence with the newer stents that you could stop it a little sooner, even 3 months if you needed to. Generally, the guidelines still say 6 if it was placed electively for stable angina, so you're just having symptoms. If you had an acute heart attack, still says a year, but a lot of times too it depends on the urgency or emergency of that surgery you need.
Great. So talk to your cardiologist or your doctor about those interruptions in aspirin. We've got a couple minutes left. What do the doctors think about a surgery a viewer has read about that reduces the size of a ventricle to help with coronary artery disease? Ringing any bells? I got nothing.
I'm not sure for coronary artery disease. I'm not sure.
Okay.
Not for reducing the size of the ventricle.
No.
No. That's not something that I've heard of.
Usually, if you have heart failure or the ventricle is dilated and it's from a blood supply issue, revascularizing that can tend to help. And sometimes, then with good medical therapy, can offload the ventricle and decrease the size of it. But I'm not sure of any specific surgical things, unless they're talking about bypass surgery, to improve the blood supply to the heart muscle, to improve the heart failure.
Yeah. I love this question. So in our last minute, let's tackle this one. How effective are stents in preventing future heart attacks? What would you say about that, John?
Yes, there's a lot of controversy, but not a lot of good data. There's a lot of, it depends on who you talk to. You talk to an interventional cardiologist like us, who say, yeah, it really helps.
You and I might disagree a little bit.
Yeah. But honestly, not really. That's why we only put it for folks who are having symptoms or an acute heart attack. So we get a lot of questions of, well, if I'm having surgery even though I'm not having symptoms, so having surgery for some other reason, should I get screened for coronary artery disease and put a stent in so I don't have a heart attack? Well, that we know is not helpful, because what do you have to do when you have that surgery? Come off your blood thinners. And as Tom just said, you come off your blood thinners, there's a risk that the stent can thrombose. So you're taking kind of a stable situation and making really an unstable situation. So
not everyone with plaque in their arteries needs a stent.
No, and there's a lot of good evidence that medical therapy is good enough. Number of trials. Take your medicines, you can do just fine, even if your heart functions low.
Well, the winner of our prize tonight is Ella from Rock Valley, Iowa. Thank you, Ella, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Based on science built on trust. Grab a copy of your local newspaper to read the Prairie Doc Perspective, a weekly health and medical column. Over 130 newspapers in the region carry the article. Ask your local paper if they print Prairie Doc today. Head to prairiedoc.org to access all archive columns.
We are familiar with the scene on television and movies. A person clutches their chest and drops to the ground unconscious. Another character starts chest compressions and help is summoned. Although cardiopulmonary resuscitation, or CPR, is often not accurately portrayed in such productions, it serves as a good reminder to all that CPR can save a life. Cardiac arrest is a general term to describe any situation in which the heart stops pumping blood to other organs in the body, most urgently the brain. Cardiac arrest can have many causes, including a massive heart attack or a deadly heart arrhythmia. Regardless of the cause, the most pressing need of any person after a cardiac arrest is, in short, restoring the circulation of oxygen to the brain and other critical organs. The American Heart Association estimates that over 350,000 cardiac arrests occur outside a hospital in the U.S. each year. These events might happen at home or in a public location. If that person is lucky enough to have a bystander educated in CPR present at the time of the cardiac arrest, their odds of surviving that event are hugely improved. The most basic and important component of CPR is effective chest compressions. CPR can also include defibrillation, or shocking an electrically malfunctioning heart to restore a normal rhythm. Many public places now keep an automated external defibrillator, or AED, on hand. A CPR class will teach participants to perform effective CPR and how to use a defibrillator. What can you do? If you have never done so, or if it has been a few years, as all things, the science of CPR has changed and improved, I would encourage you to find a CPR class in your community. If you own or manage a business, consider getting an AED and keeping it in a visible location. I hope you will never have to use these skills, but you could be the reason a family member or complete stranger survives an otherwise fatal event. Cardiac arrest is a common cause of death, but bystander CPR can be life-saving. If you are able, consider learning this heroic skill. Thank you to our guests, Dr. Waterbury and Dr. Wagener, for volunteering their time to help us learn more about the cardiovascular system and disease. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. So from all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science, built on trust. And until next time, stay healthy out there, people.
Medical education needs to undertake a holistic approach rather than just treating pathology. When learning the art of medicine, trainees and physicians build empathy, communication, and teamwork skills. The importance of humanities in medicine. Next time, On Call with the Prairie Doc.
Based on science, built on trust. Join us in supporting the Prairie Docs as we enter our 21st season. Hello, my name is Dave Heinck, and I serve on the volunteer board of the Healing Words Foundation, a 501c3 charity that secures funding for Prairie Doc programming. This past year, we celebrated 20 seasons of truthful, tested, and timely medical information from our 4 Prairie Docs, each of whom volunteers their time to answer important health questions. Thank you to our viewers who continue to help make this programming possible. You are making a difference for public health information in our state. Your donation allows us to continue to deliver on Rick and Joni Holmes' mission, set out over 2 decades ago. As a friend, supporter, and volunteer for this organization, I believe in its mission, and I know the vital impact it makes in our communities. Please continue to follow us on social media, on South Dakota Public Broadcasting, and YouTube. If you're so inclined, you may make a donation online at prairiedoc.org. Prefer not to donate online? Reach out to us via email and our staff will send you a pledge form. Thanks again for supporting our mission and Prairie Doc programming. Medical information based on science, built on trust.
Major funding for On-Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy.
Larson Manufacturing is proud to support On-Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions,
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings Madison Flandreau District Medical Society,
Pierre District Medical Society,
Sioux Falls District Medical Society,
Yankton District Medical Society,
Orthopedic Institute,
Lake Ponset Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communications.